So our next session, the title is Assessing Health Inequalities for Wait Times to Discharge in A&E at two hospital trusts in the West Midlands. So it's going to be Carla Bailey, Senior Population Health Intelligence Specialist, and Jason Gwinnett, Principal Population Health Intelligence Specialist, both at the Royal Wolverhampton NHS Trust. So I'll pass over to you both now. Thank you.
Hiya, can you hear me?
Yep.
Hello, can you see my slides?
Yes, if you can hear me, I can see your slides and hear you. Yep.
Yeah. Okay, great. So I'll kick off then. So hello all. Thanks for joining us. So my name is Carla, and myself and Jason are population health intelligence specialists from Wolverhampton, and we'll take you through our analysis of wait times in A&E at Walsall and Wolverhampton using a machine learning approach. So what was the ask? So during the pandemic, healthcare activity was massively displaced, leading to pressures in access to services in the years following, leading to a large focus on recovery. And we feel often the focus in healthcare is about absolute numbers, so overall 4-hour wait, targets, numbers on waiting lists, and we feel that inequality in access can often be overlooked. So in October 2024, the Nuffield Trust released a Quality Watch long read exploring wait times in A&E, and they found possible variations in wait times by key demographic themes, including longer waits experienced for Black, Asian and mixed ethnicity children. So the Nuffield analysis had carried out limited multivariate analysis. However, they acknowledged a more in-depth analysis to examine their findings would be useful, and it was requested that we looked at this locally. So this was one of the key findings from the Nuffield report. So a chart showing mean average time to departure from A&E by age and ethnicity, showing longer waits by age and for Black and Asian 0 to 19-year-olds and Black 20 to 69-year-olds. So the approach, we wanted to look at the variation in overall wait time to discharge in A&E. SQL was used to query and transform the dataset into a usable dataset for analysis. So data from April 22 to March 25 was extracted.
Paula, I'm sorry to interrupt, but your slides aren't moving in. I think you need to go back into presenter mode.
Okay. So this was the chart that I mentioned about mean average time to departure from A&E, showing longer waits for ethnic minority children in the younger groups. So the approach, as I mentioned, I'll carry on from the last bit. So we used Excel initially to analyse, and then we wanted to use R and Python and an independent analysis from both myself and Jason and to compare the results. And this was just to enhance on current modelling techniques that we use, and to use a machine learning approach which is like better suited to large complex data. Okay, so the explorative analysis. So weights were left skewed with significant longer waits. The mean wait time was 256 minutes compared to 173 minutes. There were large variations in wait time linked to age, whether admitted and patient acuity, so the severity of the attendance reason. And there's some variation in wait times between gender and ethnicity. And there were differences between hospital trusts despite them broadly covering the same patch, so Walsall and Wolverhampton. So this was the Excel chart that we managed to replicate by Nuffield, but we could split it further by age groups, so showing some longer waits for ethnic minority children, but we wanted to expand on this and look at some other of the confounding factors. So the multivariate analysis approach, the dependent variable was total wait time from arrival to discharge in minutes. Outlier waits were removed, and waits of longer than 24 hours and 0 waits were removed also. And we decided to remove missing data for discharge group and gender, because this was small numbers. But for deprivation, ethnicity and acuity, a category of unknown was included in the model as this was larger numbers. So as I mentioned, Python versus R, two separate analyses, and it was quite a lengthy piece of work, but due to the lightning talk, we'll just go through a small snapshot of what we did now. So the actual approach continued. So we wanted to try and use approach of machine learning and traditional statistics, but this can often be based on just assumptions and theories. So we wanted to stretch that a little bit more. The actual difference between Python and R, The data split was 80 to 20% in Python and 70 to 30% in R. The independent variables, so key demographics, age, gender, ethnicity, deprivation, quintile, and then things around the attendance itself. So arrival time, discharge group, acuity, admitted, month of admission, and winter flag. And for our arrival day, financial year, and arrival group was also used. The data preparation was a little different. So in Python, acuity was numerically encoded, and for in R, it was left as a categorical variable. And also I thought it was important to cyclically encode arrival hour. So there's a relationship between 12 o'clock and 1 a.m., which is important for A&E attendances. So the model was used, as I said, a mixture of traditional and machine learning. In Python, linear regression was used as a base approach just to demonstrate that it wasn't suitable. And then tree-based methods were used, so random forest and gradient boost. And then in R, initially, a Poisson model was used, as this is best suited to count data, but it showed over dispersion, so variance larger than the mean, and this is due to the longer weights. So negative binomial was then used. And whilst this gave nicely and easy to interpret coefficients, tree-based methods were adopted just to try and improve on predictability and accuracy. The models were assessed using R squared, and for R, residues were also looked at, and for Python, some partial dependency plots to look at the relationship between the independent and dependent variables. And Jason is now going to take you through the results.
Okay, thank you, Carla. I think rather than me trying to share my slides again, can I just tell you to move them on, Carla? It might be easier.
Yeah, okay then, sure. Well, that's fine. Hopefully you can see the results right now.
I can see now. Can people hear me? Take that as a yes. Okay.
I can hear you, so.
Okay, brilliant. If you can hear me, everyone else can hear me as well. So, okay, so the following charts contain a selection of our key findings using both approaches. As Carla said, we've not included everything. It would take way too long to go through it all. These summary tables here are comparing the model assessment for both approaches. Root mean square error shows the average size of the prediction error. It's quite large in this instance because the data is so heavily skewed and long weights are impacting on this error. Given this, we felt mean absolute error more appropriate in assessing model fit. It's less sensitive to extreme weights. So both approaches, it's lower than the RMSE, but it's still high for all models when we consider that the median weight in A&E overall is 173 minutes. So in terms of model accuracy, you can see that tree-based models such as random forest, gradient boost, and XG boost show improvements on baseline models. It's not substantial though. We think there's probably possible data ceiling with these models. Predictive accuracy is still pretty reasonable as measured by R square, given the skew in the data. We felt that hospital data is rarely normally distributed, and given our main aim was not to predict wait time to a high degree of accuracy, but to determine what factors, if any, impact wait time, we concluded this is sort of satisfactory with what we were looking at. It's also worth mentioning that in the real world, even sophisticated models struggle to explain these high variance in predictions. So next slide, Carla. So this is an extra series of plots that Carla did in R, and they look at the residuals plotted for each model. It just demonstrates how hard it is to predict. You slightly get a better pattern for XG boost. So next slide on again. So these charts show feature importance for both approaches. It's a relative measure of how important each variable is in the model. The charts are gradient boost as displayed here in Python and XG boost for R. Both approaches highlight patient admitted and age are overwhelmingly the most important factors on wait time. Acuity comes out as more important in the Python approach, whereas arrival group emergency ambulance is more important for R. Both show similar importance of time of arrival and discharge group stream assessment. But both approaches show ethnicity and deprivation not to be important, which is a key thing we were looking at. So the next slide is these are the partial dependence plots that I did in Python. They're a nice visualization technique that showed individual impact of the variable on wait time. The direction shows the effect on weight. So here, an upward trajectory shows the variable is correlated with increasing weight and vice versa. And a flat line crucially shows no effect. So you can see here there's a strong relationship between time and age and emitted flag and acuity. There's also a link between wait time and stream assessment. Next slide, Carla. And then arrival time is also showing some impact on wait time. But crucially, what we're most interested in, ethnicity and deprivation do not seem to be impacting on wait time. So next slide. So in conclusion then, we were able to reassure decision makers that there was no large equity issue by deprivation and ethnicity, at least on A&E waiting times. The focus can now shift to other potential areas where inequality is a factor, such as people leaving A&E before being seen for treatment, where we've looked at initial univariate analysis, and this suggests potential possibility of disparity. Quite a crucial thing for us is that we were able to apply machine learning methods in-house, a more traditional approach in R and a more pure machine learning focused approach in Python. We've had experience before where external companies are brought in to do similar pieces of work. Often these can be presented as a black box where we are presented with findings and there's no way to really appraise the outputs or methods used to a high degree. Which model works best? We felt in this instance they're both quite similar, which is quite reassuring. The Python approach is slightly quicker, but we do think that where you have time, it's worth using a combination of both. A key finding we found is that it's quite difficult to simplify the findings of such complicated and nuanced analysis, and often a quick answer is required and expected. But also we find that senior managers can prefer a BI dashboard approach, and our outputs don't really fit that style. We're more about the interpretation rather than pretty outputs. Limitations, we may be missing many predictive variables, and in fact the R-squared showing that, such as wherever on a given day, baseline virus activity, GP appointment availability. Some of these are not routinely available. We also thought about using additional approaches like deep learning and machine learning and fine-tuning, but we were constrained by time and capacity and storage and processing limitations. I did try running fine-tuning, but after half an hour it was just running on and on and on and getting nowhere because of the size of the model we're using. It's easy though to go down rabbit holes and keep trying to improve on models. Sometimes you need to accept the data, especially complex hospital data, is not going to conform exactly to one model. Not all models will be able to explain all variability. So next slide. So thank you, and that's a quick run through, and any questions from the audience?
Brilliant. Thanks very much, Carla and Jason. We are at time now, so we might not quite have time for questions because we are going into a break. But if you did have any time to respond to the questions in the chat, that would be really helpful. But yeah, really, really interesting presentation. So thanks.
Okay, thank you.
For your time. So